Sir, you need to unmute yourself. You're muted.
Yes.
Okay, sir. So, yes. You can start, sir.
Okay. Hello.
Yes, sir.
Good evening. Very good evening to all. So, myself, Dr. Ramesh Chaudhary from SMS Medical College. I would like to welcome you all in the 5th week class. Under the NNF shine on fluid management and the neonatal shock. Am I audible to all of you clearly?
Yes, sir, you are here. Please make it full screen, sir.
Yes. So, fluid management is very critical for all the newborn, though it is not necessary to give all the fluids via infusion. So maintenance of fluid and electrolyte balance is integral part of neonatal care. And in the most of the neonatal cases, breast milk is sufficient to provide required fluid. So for the maintenance and growth, all the purpose, but it is to be used in the stable new, those who can accept oral feeds. But few of the newborns, those who are sick, they need IV fluid and electrolyte for sustenance while going through the crisis. For our goal of early fluid management is to allow normal weight gain and to allow them to lose weight in the early week. So today's learning objectives are to identify babies who need IV fluid. It doesn't mean that all the admitted newborns need IV fluid. So we have to identify which newborns need IV fluid. So we have to calculate the daily fluid requirement and the electrolyte requirement. We have to administer IV fluid using either micro drip set or syringe infusion pump. We have to monitor the babies receiving IV fluids, and we have to adjust the feeds and fluids altogether, so as not to exceed the daily requirements. So, what are the indications? So I already said in the outset that any newborn who is not tolerating enteral feeds are suitable for starting on IV fluid. Second category is the babies who are having shock. Third category, babies who came out of severe prenatal asphyxia. And third one, surgical conditions like abdominal distension because of prenatal GI anomalies, atrachia, enterocolitis, and all. So these are the categories which are suitable for starting on IV fluids. Rest all may be started on the enteral feeds. So hope this is clear with all of you. Then, so choice of fluid, which fluid is to be given? So at the start, for the next 48 hours of the life, most of the babies require electrolyte-free fluid, that is dextrose 10%. And sodium supplementation is usually not required in the first 48 hours, except when we need them for the volume expansion, like in shock. But after 48 hours, if the baby is passing urine 6 to 8 times a day, we can use commercially available fluids just like Isolite P and others. So how to administer IV fluids? So we can either use micro drip infusion set or syringe infusion pump. These two devices are available with us in the most of SNCUs and ICUs. So micro drip set or infusion pump, they are mostly required. So in micro drip infusion set, that is commonly known as the PDA set, 1 ml is equal to 60 drops. So 1 ml, when it is goes, it creates 60 microdrops. So number of drops per minute is equal to the fluid rate of that hour. So if baby needs 6 ml per hour fluid, then we have to adjust the microdrip sets at the 6 microdrop per minute. So adjust the rate carefully and check periodically to ensure delivery of correct amount. Because as the baby is moving the limbs or IV port is getting thin, so they may change the fluid rate. So it is very imperative to periodically check the drip rate if we are using micro drip set. So syringe infusion is more reliable because it can deliver even smaller volumes and medications as well. For here, for this, we use PMO line that is connected to a syringe. In the syringe, we have filled the fluid and then it is connected to the IV cannula. Though it is also useful for delivering the medications. So how to administer IV fluid? So after deciding that this baby is in the need of IV fluid, then fluid choice and device. So we have to prepare the fluid of that. So it is to be prepared using all aseptic precautions. If we don't follow this, this can create a disastrous situation in any SNCU or NICU. So please always use aseptic precautions as we are entering into the bloodstream of the baby directly. So while preparing, wear sterile gloves after observing your hand hygiene. Then fill the syringe, pump, or microdrip set with that intended or decided fluid, either D10, ISOP5, ISOP10. And if you want to give medications, then fill that medications. Then calculate the drip for 24 hours. Make sure don't fill whole of the fluid of the 24 hours in a single sitting. So you have to fill microdrips for 8 hours only. It is to be replaced in each and every nursing shift. So in case of a fast runoff, it will not go a much quantity. While administering, you have to strictly maintain the input-output chart and review it every 8 hours. Include the volume of medications and flushes in the total fluid calculation. So whenever we are administering the fluid, we have to take on the account of all the fluids that are going inside the baby, even feed, other medications or antibiotics or other supportive medications, and flushes given to the cannula. Then secure IV cannula properly using a skin-friendly adhesive, and we need not to splint the extremities. So remember, before infusing IV fluid, check the expiry date of fluid. Then seal of infusion bottle or bag for its intactness. Fluid is clear of any visible particles. So many times we see the incidences that fungal threads were grown or fluid was contaminated. It is altered color. So we have to be very clear. You should instruct your on-duty doctors, nurses regarding that. Then change the syringe, PMO line and micro drip set every 24 hours. to avoid contamination, nosocomial infection. And after using that particular bag, we have to discard all unused fluids. Don't keep the opened bottles after its use. Use it immediately and discard it. So, about fluid requirement as per the day. So, we have divided the babies into two categories: those who are weighing less than 1500 grams, and another group is weighing who are more than 1500 grams. So, as the day progresses from the day 1 to day 7, for the babies who are weighing less than 1500 grams, it starts at 80 ml per kilo per day, and we keep on adding 15 ml per kilo per day for every incremental day until it reaches 150 ml. Then it becomes static. And those who are weighing more than 1500 grams, we usually start at 60 ml per kilo per day. And same, we keep on adding 15 ml per kilo per day for the next days until it reaches 150 ml per kilo per day. Volume of fluid, usually it depends on the birth weight, gestation age, and the postnatal fluid. Few of the preterm, they are more in need of fluids as compared to term babies because of the insensible losses. If we are not using uh, incubator and insensible loss prevention strategies. So we always calculate fluid requirement based on volume of ml per kilo per day. So whatever we fluid we administer, it gives some calories, and most of the calories they are used in the resting metabolic rate. So average estimate for the baby's requirement in the kilocalories per kilo per day. The resting metabolic rate takes much of the account, that is around 40 to 50 ml, 50 kilocalories per day. Then energy is stored 20 to 30 kilocalories per day. And few of the calories are going for the synthesis and few of the calories are being expensed on the excretion. So total calorie intake would be around 90 to 120 per kilo per day is sufficient for the low birth weight newborn. So calculation time. So you please all take your pen and paper or exercise notes. So we have to calculate IV fluid for a 4-day-old newborn with birth weight of 1.2 kilo. Total fluid requirement on day 4 of life. What would be? So for that, you may use this table. The baby's weight is 1.2 kilo and the day of life is 4 kilo. So we can start with 80 and the day 4 requirement is 125. So when we use this formula, so as per table 6.1, 125 ml per kilo per day multiplied by 1.2 kilo of baby's weight, it comes to 150 ml per day. So 150 ml per day is for a 24 hours period. When we divide 150 ml divided by 24, it comes to 66.2 ml per hour. So as I already said that we have to divide, if we use burette or pediatric drip set, we will divide all 150 ml in 3 parts. So then it comes 50 ml for each nursing set. If we use via infusion pump, then we may fill it 50 ml and start at 6.2 ml per hour. So when we write down our fluid order, it goes because fluid of choice on day 4 is ISOP, 150 ml in 24 hours at the rate of 6.2 ml per hour with a syringe pump. If we are using syringe pump, if we don't use syringe pump, then we may write as because our rate was 6.2 ml per hour. And I already stated earlier that number of microdrops per minute is the rate. So here we can use 6 microdrop per minute with a microdrip set. Give this fluid with microdrip set at a rate of 6 microdrop per minute, or with syringe infusion pump at 6.2. So whatever you are using, whatever you are comfortable, you may use. But if you are using microdrip set, periodically monitor for change in the drip rate with the limb position or movements. So in case it changes, we have to readjust the fluid rate. So now coming to the monitoring the baby's own IV fluid. That was our next learning objective. The inspection of infusion site every year, because when we all know that there are so many incidences of IV fluid leak, extravasation related injuries. So we have to be very careful about the infusion site from where the cannula is entering the baby's body. So we have to always look for the redness or swelling around the insertion site of cannula. In case we found that there is local redness or swelling, it indicates that cannula is not in the vein and fluid is leaking. Once fluid is leaking, it will create so many problems. It will create pain. It will be depriving the baby of required calories. It will be depriving babies for the fluid. It is creating a source of infection, or if we are using some other medications, it may cause the necrosis. So we have to be monitor the local site for the earliest evidence of extravasation. And the earliest evidence of extravasations are redness and swelling. If the swelling or redness is seen at any point, stop the fluid. Whenever you see that there is a swelling, there is a redness, stop the fluid. Stop the fluid, remove the cannula, and establish a new IV line in a different way. Then check volume of the fluid infused and compare to the prescribed volume. Just like we already planned to give 6 microdrop per minute, or we prescribed 6.2 ml per hour per minute through syringe pump. So once we start, then every hour we have to look at the pump for the desired volume achieved. So we have to record that in the recording sheet. The essential stationery that is having hourly fluid. So after that, we examine the local site. We are monitoring the volume of fluid infused in a given hour. Then we have to monitor the glucose at every nursing shift, 8 hourly, or depending on the baby's glucose level. If the glucose level is less than 45, then we have to treat for the low glucose level, and we can plan frequent monitoring of the blood sugar level as per the unit's policy. But if the blood glucose level is more than 150 on 2 or more readings, 1 hour apart, then we have to reduce the glucose infusion rate and check glucose levels after 30 minutes. So in short, while baby is on IV fluid, we have to monitor IV site for extravasation that we can decide by the using local redness and swelling. Once we see that it is extravasating, we have to stop the fluid, remove the cannula, and establish a new line. Whenever we are monitoring, we have to monitor what intended quantity of fluid is gone to the baby or not. Then we have to monitor for the glucose and to decide it. Remaining monitoring is the weight the baby daily using the electronic weighing scale. And for the initial days, we already said that we are permitting a desirable weight loss, but not excess weight. Then we have to take to the account urine output that roughly can be estimated by the frequency or by the diaper weight, depending on the unit's policy, or accurately we can measure by the weight nappies on the same or different. Once we see that baby is having oliguria, means that the baby's urine output is less than 1 ml per kilo per hour over a period of 6 hours after the baby's age is 48 hours. So if that is the case, then we have to decide accordingly. We have to look for the signs of overhydration as well. Why overhydration happens? Baby may be excreting less of the urine, or we have calculated not according to the appropriate weight. So signs of overhydration, we have to monitor, that is puffiness, excessive weight gain, or increasing distress. So for all calculations of fluid and feed and total fluid requirement, including drugs, we use the birth weight as a benchmark weight. So birth weight is for all calculations unless baby crosses it after birth. Then after that, we use current weight. Once birth weight is regained, we use actual weight. So until baby crosses his birth weight, we use only birth weight. Once it crosses, then we use current weight. So daily monitoring. If the daily weight loss is more than 5%, you monitor the baby. If you observe that baby is losing more than 5%, we have to increase the volume of fluid by 10 ml per kilo in a day. Usual increment was 15 ml per kilo per day. But if baby is losing weight more than 5% on a particular day, that is beyond your expectation, then we have to give excess of 10 ml per kilo for that day, and then we have to reassess. If there is no weight loss or there is weight gain in initial 3 days of life, we don't give extra fluid increments. So if you're monitoring, if baby is losing more than 5, give a 10 ml plus increment. If baby is gaining weight, we skip the fluid increment or keep the fluid rate at the same day. If there is excessive weight gain, then we also decrease by 15 to 20 ml per kilo per day. So both ways we have to use our monitoring by weight. So weight gain to be within limits, urine output to be monitored, extravasation to be monitored, glucose levels to be monitored, and infusate of every hour to be monitored. So total monitoring is infusion site for extravasation, infusate volume in a given particular hour, in a given particular nursing shift, in a given particular nursing day. Then blood glucose, gate hourly, and plus minus depending on the hypo or hyperglycemia. Then weighing daily, monitoring for the urine output, signs of overhydration, and deciding the fluid. If there is oliguria and weight loss, we may increase the fluid intake by 10 to 20 ml per kilo. If there is still oliguria with weight gain, that is a different situation. There is weight gain, but oliguria. In the first situation, there was oliguria with weight loss. So if the oliguria with weight loss means dehydration, in that case, we will increase the fluid. But if there is oliguria, but with weight gain, we will decrease the fluid and evaluate for the renal function. In case of acute kidney injury, we just replace insensible losses, that is 25 ml per kilo in term babies and 50 ml per kilo per day for the preterm babies. As electrolyte-free fluids are D5, D10, and urine output we will replace as half normal saline, that is 0.45% NS. During fluid restriction, glucose infusion rate should not be below 4 milligram per kilo per minute to avoid hypoglycemia. So it may necessitate few times to give more dextrose concentration. If baby is having intestinal obstruction, we have to replace gastric aspirate fluid with half normal saline. If the gastric aspirate is coming as bilious, we have to replace it with Ringer's or saline on volume to volume basis. Like your baby's aspirate was 10 ml for 8 hours, then we will give 10 ml extra for that 8 hours. If a baby is having dehydration, serial recording of weight is the most reliable sign of assessment of the severity of dehydration. Like a baby was born with weight of 1 kilo, he lost his 100 grams over next 3 days, means he is now 900 grams, then he lost 10% of the weight. So serial monitoring of the weight is the best and accurate way, reliable way of assessing the hydration status of the babies. Assessment of dehydration by using physical science, like we are doing for the other infants, is less reliable for the newborn. Dehydration is to be corrected slowly over 24 hours for the newborns. For the most of the newborns, we use for deficit correction half saline. Half the deficit is corrected over 8 hours and remaining over the 16 hours. That is very stark with the term. This is in addition to the maintenance needs plus ongoing losses. So if a baby is having dehydration, we have to plan it over 24 hours. 1/3, half of the dehydration is to be corrected in 8 hours, remaining in the 16 hours. Plus maintenance fluid of the day and weight along with ongoing losses. If there is severe dehydration, secondary to diarrhea or something else, we may use plan C of the IMNCI. Potassium, 2 millicurie per kilo per day is to be added after urine flow is established. Always make sure to document passage of urine before adding potassium. 1 ml of IV potassium chloride solution is containing 2 millicurie of potassium. So 1 ml IV KCl 200 ml is to be added. So third situation, the baby is a bit stable. He's on us also on the enteral feeds. So we have to adjust as per the IV fluid requirement. Initiation of oral feeds, we can start at any point of time whenever we feel that baby's clinical condition is stable, improving. What is the choice of enteral feed? That is the mother's own milk, mother's own breastfeed. So if baby is able to directly breastfeed, we may offer direct breastfeed. If the baby is not able to breastfeed directly, we may use expressed mother's milk by cup, spoon, or tube. So whatever way baby is able to feed, we can offer. There is no necessity that we can offer only breastfeed. We may use tube feeding and cup feeding as per the baby's condition. If the baby is tolerating feeds, we may increase the volume of feed by 20 to 40 ml per kilo per day. We may use lower range for the VLBW babies while decreasing the volume of IV fluid. So whenever we increase the feed volume, we have to decrease the fluid volume so as to maintain total fluid of the day. So whenever we increase, like we gave an increment of 20 ml per kilo, so we have to adjust as per IV fluid. So total fluid is to be charted as 6.1 only. So what was the 6.1? That gives us a 2 categories based on birth weight. That is, baby is less than 1500 gram or more than 1500 gram. And what is the postnatal day? So with a daily incremental doses starting from 80 or 60, depending on the weight band and postnatal day. So we have to calculate all the fluids at once. Means IV fluid, enteral feeds, boluses, medications, and flushes. So once the baby is receiving 100 ml per kilo per day of enteral feeds, we may discontinue IV fluid. So subject that baby is not having any abdominal distension and vomiting. So we have to give priority to the enteral feeds to all eligible newborn who are not having any contraindication for enteral feeds. So we have to calculate now. So a baby who is born at 31 weeks with a birth weight of 1200 grams, he is hemodynamically stable and on CPAP by nasal drops. What is the requirement for day one? So we will start for that weight 80 ml per kilo per day. And for the day one, it is same 80 ml. So 80, if we multiply by the 1.2, it comes to the 96 ml per day. So total fluid for that baby for minimal enteral nutrition is 30 ml per kilo per day. It comes to 36 ml. So 36 divided by 12 means we want to divide 36 ml of mother's milk in 12 equal aliquots. That comes to 3 ml each feed. So total feed volume is 36 and each feed volume is 3 ml. 3 ml, if we give 12 times in a day, it will come to 36 ml. And remaining, we can give via IV fluid. Like total requirement was 96. 96 minus 36 is 60 ml. So remaining 60 ml, we may use dextrose 10% divided in 3 equal parts for each nursing shift. That is 20 ml 8 hourly and 2.5 ml per hour if we use by the syringe pump, or 2 to 3 microdrop per minute if we use burette or pediatric drip set. So that would be the fluid plan for those babies who are hemodynamically stable on the CPAP. Now, we are coming to the day next. So next day, the baby's requirement from 80, it goes to 95. Calculating weight is still same 1.2 until it crosses back 1.2. So now it is coming to the 114 ml per day. So total feeds, now we increase from 30 to 60 because yesterday we started only 30. Today, day 2, increase the feed to the 60. That is coming to the 72 ml. 72 ml total day. If we divide in equal to hourly duration, it comes to the 6 ml. So 6 ml each feed. Total food requirement is 114. 114 out of 114, 72 ml is going through enteral feeds. The remaining 42 ml is to be given by IV fluid. Same fluid, dextrose 10%, 42 divided by 3 for each nursing shift is 14 ml 8 hourly. 14 ml 8 hourly can be given 1.75 ml per hour by infusion pump and 1 to 2 microdrop per minute by pediatric drip set. So same baby who is still stable, calculating weight would be the same 1.2 kilo. Day 3 fluid requirement after third day's increment is now coming to the 132. We are now on 100 ml per kilo of enteral feeds. that is coming to the 120 ml per day. In divided equally 12 doses, it comes to 7 ml for each feed. So once a baby who is receiving 100 ml per kilo of feeds, we may stop IV fluid. We already discussed that we can stop the IV fluid if the baby is receiving 100 ml per kilo of enteral feeds. So this baby received IV fluids just for 48 hours. So remember, whenever we skip or uh, we don't give IV fluids, it decreases the chances of infection, chances of extravasation, chances of medical legal cases. So day 4, same baby is stable. Day 4, fluid is 125. Calculating weight is still 1.2. Total requirement is 150 ml per day, divided in 12 feeds. So total oral feeds on day 4 is 13 ml 2 hourly without any IV fluid. So now baby birth weight is 1.2 kilo with a gestation of 31 weeks, hemodynamically stable, and CPAP. Day 1 fluid order. Same 80 ml, 1.2 kilo weight is total 96 ml. Total fluids we can start 80 ml per kilo per day. Means here we are skipping all the IV fluid requirement from the day 1 as the baby was hemodynamically stable. If your unit's experience, unit's policy permits, this is the best fluid order for the baby. So it is coming to the 96 ml total feed. If we divide that 96 in equal 12 parts, it comes to 8 ml. And 8 ml 2 hourly feeds is equal to 96. And that can be given in the form of the expressed breast milk or donor human milk if it is available from your milk bank or CLMCs, or we may use preterm formula. The same increments over next days we can follow. So the key message is regarding fluid therapy is that use dextrose 10% for the first 48 hours. After 48 hours, we may use 5% dextrose containing sodium potassium as maintenance fluid like ISOP. Use syringe pump or micro drip infusion set to administer small volumes of IV fluids and medications. Weighing serially and monitoring urine output is the best way to assess the hydration status. Enteral feeds as soon as baby is hemodynamically stable, and early total enteral feeding is feasible, safe and advantageous, and it should be initiated in all stable babies like in the second example. So now coming to the next important part, that is neonatal shock. So shock in the newborn is defined as overperfusion of the neonatal body tissue where the body's demand for the oxygen and nutrients are not met. This can result in tissue level hypoxemia, acidosis, and consequent irreversible tissue damage. Shock and hypotension are not synonymous. Hypotension means low BP is a late sign. So our aim is to identify shock at early. Hypotension means BP is lower than expected reference range using Zebra chart. So how to identify the shock? The first sign for any shock is the tachycardia. Any baby whose heart rate is more than 160 per minute is the earliest sign of the shock. But remember, heart rate can be increased if there is pain, stress, hyperthermia, or drug effects. So we have to look Maybe in totality, whenever we see a baby is having heart rate more than 160, after quickly ruling out all the pain, stress, hyperthermia, drug effect, we have to think about the shock. Next, how we can identify, that is the capillary refill time or capillary fill time. The rate at which the capillary fills following a emptying pressure is the adequacy of tissue perfusion. How we can use it? We just take the central part of the body, like sternum. We have to apply gentle pressure. The pressure should be just enough to blanch the skin. Not we have to compress the chest. We have to just gently press for 3 seconds. How we decide 3 to 5 seconds? It's just by counting 3-digit number like 1001, 1002, 1003, 1004, 1005. Then lifting your finger back and counting it again. So when we count again, then we have to look for the blanched area, it getting refills. If normal capillary fill time is less than 3 seconds, whenever it is beyond 3 seconds, it indicates poor perfusion, poor circulation, or in the few of the cases, it may be hypothermic babies. So other features of the shock, poor peripheral pulses, pallor, mottling of the skin, cold extremities, decreased urine output, lethargy in condition, and low blood pressure. Whenever you are feeling that in the SNCU clinical baby sheet, the nursing chart carries each and every. First is activity. And so remember, low blood pressure is a very late sign. And we have to identify shock very early. So what is the management of the shock? Shock management is depending on the cause, but supportive management remains same for all, is maintaining temperature, airway, breathing, and circulation. We have to maintain normothermia, that is 36.5 to 37.5. We have to avoid hypoxia. We have to maintain oxygen saturation between the range of 91 to 95. We have to ensure euglycemia, that is blood sugar level more than 45 milligram per deciliter. Then specific management. Specific management is depending on the cause of shock, but restoring perfusion is the cornerstone. And that we can achieve easily by giving fluid boluses. The fluid bolus is the choice normal saline. I already said that during first 48 hours, we don't use any electrolyte solutions except babies who are in shock. If the baby is having shock, we can use normal saline. The dose of the normal saline is 10 ml per kilo and to be infused over 20 to 30 minutes. So for example, if a baby is having weight 3 kilo, we have to give 10 ml per kilo multiplied by 3 kilo, that is 30 ml. And that 30 ml to be infused over 30 minutes. So after giving a bolus, we have to again check about the improvement. Improvement can be just by decrease in the heart rate, improvement in the CRT. If we observe that there is no improvement or partial improvement, like persistence of tachycardia, poor CRT, we may repeat the bolus with the same dose. So after giving boluses for 2 times, still baby is having poor perfusion, we may start vasopressor support. Along with vasopressor support, we may look for the underlying cause and we may try to treat them. We use few drugs to enhance myocardial contractility and consequently cardiac output. As we know that some degree of myocardial depression is present in all type of shock. So most commonly used vasopressor in neonatal practice is dopamine. Dopamine has three effects on preload, myocardial contractility, and afterload. And most important effects are on the afterload and contractility. So starting dose of dopamine is 10 microgram per kilo per minute. If baby shows no improvement, then dose may be increased by increments of 5 microgram per kg per minute every 30 minutes to a maximum of 20 microgram per minute. So vasopressors, how to give vasopressors? For that, we may use syringe pump again. We use here insulin syringe because insulin syringe is having 40 parts in a 1 ml and dopamine is 40 milligrams per ml of vial. So it is very easy for calculation as insulin syringe is also having 40 parts and 1 ml of dopamine is also having 40 milligrams. So each 0.1 unit is equal to 1 milligram. So if a baby is weighing 2.5 kilo and we want to start dopamine at the rate of 10 microgram per kg per minute, so total dose would be 10 multiplied by 2.5 is 25 microgram per minute multiplied by 60 minutes for an hour and 24 hours for a day. That comes to 36,000 microgram for a day. 36 micrograms means 36 milligram. That is equal to 0.9 ml of dopamine for 24 hours. We calculate all the fluids for each nursing shift. So this 24 requirement will be divided by 3, that is 12 milligram or 0.3 ml of dopamine for 8 hours. So how to give? If we want to, we add 0.9 ml of dopamine in 24 hours and give at 1 ml per hour with syringe pump, we will give dopamine at the desired rate 10 microgram per kg per minute. If the pump is not available, then add 8 hours dose means 0.3 ml or 12 milligram of dopamine to 8-hour maintenance fluid and run at the desired rate of maintenance fluid. After starting dopamine drip, monitor for the perfusion by heart rate that is coming to the normal range, capillary refill time that again coming to the normal range. If available, use a non-invasive blood pressure monitor for improvement in the blood pressure. NIBP can be monitored. Once we start inotropes, assess every 20 to 30 minutes. If there is appropriate response, then we may keep it the same. If there is no response, we may increase dopamine rate by 5 microgram per kg per minute by increasing the infusion rate to the 1.5 times. Then if again, we can again increase the rate to the next increment, that is 2 ml per hour or 20 microgram per hour. On the other hand, once the perfusion is improved, we have to decrease the infusion rate by the decrements of again 5 microgram per kg per minute. Once we decide that baby is improving, we can plan decrease. If despite giving maximum dose of dopamine, that is 20 microgram, baby continues to be shocked, we may use another inotrope, that is dobutamine, or any other inotrope as per your unit's policy. So many of you may be thinking that dopamine, it is very less used in few of the units, but for the first liner starters, it is the choice after boluses, and remaining inotropes is to be used as per the unit's policy, as per the consultants of the units is to be decided. So we can also use steroids for the shock. Hydrocortisone may be considered in the newborns who don't respond to the maximum dose of dopamine and dobutamine. The maximum dose for both is 20 microgram per kg per minute, and hydrocortisone may be given in a dose of 1 milligram per kg 8 hourly. Then depending on the response, we have to assess 6 to 8 hourly. We may repeat dose every 8 hourly for 2 to 3 days. Unresponsive. Neonates with shock may not respond to above treatment when there is associated hypoglycemia, hypoxia, hypothermia, hyperkalemia, anemia, severe sepsis, pneumothorax, cardiac tamponade. So whenever shock is not improvement, we have to think about other causes as well. If a baby's hemoglobin level is less than 12, we may plan transfusion, and we may plan for the referral after stabilizing TOPS. Therapeutic endpoints while treating shock. Treatment should be modified as per the assessment and response to achieve. We started with the capillary fill. So our capillary fill time should be less than 3. Heart rate 120 to 140 and less than 160. Normal pulse volume, warm extremities, normal blood pressure, normal sensorium, and urine output of more than 1 ml per kilo per hour. So how to wean inotropes? We already discussed while escalating dose. Once hypotension improves, means normal blood pressure for 6 to 8 hours, tissue perfusion improve, we can taper inotropes at the rate of 5 microgram per kg per minute every 1 to 2 hourly, and while monitoring to keep all therapeutic endpoints within our set limit. Inotrope to be tapered if BP is more than 90th centile at any point of time, if the baby is stable for 6 to 8 hours, and dose of dopamine and dobutamine should be reduced 5 microgram per kg per minute, 1 to 2 hourly. Omit the inotropes when the neonate has been stable on 5 microgram per kg per minute of dopamine, and inotrope which was added last is to be tapered first, just like you started with dopamine, reached maximum, then started dobutamine, maximum, then steroids, maximum. So whatever is came last will go first. So this is the sample monitoring sheet, which covers the temperature, heart rate, respiratory rate, pulse oximetry, CRT, mean blood pressure, urine output, Downey's, Lebanese score, blood glucose, electrolyte, calcium, uric creatinine. And key message is monitor all the sick babies for the early signs of shock. Whenever you feel that there is shock, treat it immediately, and supportive care with fluid resuscitation and inotropes are the mainstay of the treatment. Thank you.
Thank you, sir. We have one question in the chat box, sir. What is the criteria for hypoglycemia in the neonates for the first 24 hours?
The first 24 hours. It is also hour specific. Like,
Sir, I think you're muted. Not able to hear you. So if any student has any question, they can just unmute and ask, or they can just write it in the chat box. So, sir, we have another question. In a previous session, the amount of total fluid for the day were taught as 80 ml per kg per day for 1 to 1.25 kg. Today, it's 80 ml per kg per day for 1 to 1.5 kg baby. Which to follow?
I don't know about the previous section, but it is for all classical teaching. Baby's weight for the fluid decision is 1.5, less than 1.5 or more than 1.5. And for more than 1.5, it is 60 ml is the start and 50 ml per kilo per day is the incremental dose. And for the less than 1.5, it is to be started at 80 ml per kilo and increment of same 15 ml, along with a daily monitoring of urine output, hydration status by the weight, and to be given extra or lesser fluid depending on the weight and hydration of that current day.
I think Dr. Prakhar, it is clear that it is actually 1.5. There is no confusion in this. So it is less than 1.5 and more than 1.5.
Even if it is there, we will check it and with the previous and will clear.
Any other doubt you can clarify. You can also unmute yourself and you can ask also.
Hello, sir. Good evening. Hello,
Yes,
sir. Good evening.
we can hear you, sir.
Yes.
Sir, just wanted to ask, how do we choose the type of inotropes to be used in a patient?
How we choose the inotropes depending on?
Sir, like at what conditions should we use NORAD, sir? At what conditions you should use EDRI, then DOPA and dovitamin, sir?
Yes. So that was the question back in our mind as well. To keep all of us on a same platform as a startup, we use bolus once or twice to achieve our therapeutic endpoints. If a baby is not improving on bolus, we start with dopamine, as these are FBNC or NNF guidelines is saying. For rest of the inotropes, directly starting adrenaline or dobutamine or some other, we have to consult our own unit in accordance with our unit's policy to keep all of you on same pace. That's why it is being decided we use only dopamine at the outset as a first inotrope after assessing the success of boluses for 2 times.
Yes, sir.
That is to be used in consultation with your unit's on duty senior consultant or unit's policy.
So primary thing is, first thing, that you should be able to identify the shock, that yes, this baby is in shock. First primary thing is this: you should not miss very early signs of the shock, like tachycardia, CFT, which is delayed. So the poor pulse volume. So that decrease urine output. These are the things which has to be identified first. Then, as sir said, just go over the bolus followed by dopamine, and the further things you can discuss with your consultant there who is available. And depending on that, you can decide what is the condition, which inotrope will be better for that particular condition.
So deciding inotrope is a good thing that eventually you are going to do any day. But identifying shock and helping baby with supportive care along with early initiation of the boluses, monitoring for the response, and titrating the dosage of inotrope if blood pressure is going above 90 centile for that is. So I think that is more meticulous than deciding because titrating dose frequently is much harder than deciding inotropes. So many times, even with all possible physiological explanation, few inotropes work better with some babies and few inotropes didn't work even with classified possible etiology.
What it's up. Thank you.
But But your question was very good, Abhishek. Thank you. So at last, I can ask one question. Is it possible to, you can all unmute and reply, or you can type in your chat box. Is it possible to start total enteral feeds if a baby is clinically stable, even if he's around 1 kilo, 1.1 kilo, or 1200 grams?
Yes. Yes, it's possible.
Okay, one baby is in shock on day 1. On day 1, with signs of dehydration. Baby lost weight more than 10%. So, how to decide about the feed? Baby was born at 1.1 kilo and admitted to your unit with 1 kilo weight only. He lost 100 grams over a day. He is in shock. Is it possible now to give any feeds? How to start? You'll start with TABC? We'll start with the
Yes.
TABC,
Yes,
fluid
yes, TABC.
resuscitation. And once the baby is stable, then we can think of the feeds. So baby's clinical condition is not like in the theory lecture. They come with very varied presentation. So shall we need or few more questions?
Some
Yes.
very important take-home points which Sir has already told. One is identify which baby needs an IV fluid. Don't give IV fluid here and there. Just identify the baby which needs an IV fluid. Try to switch the baby as soon as possible to the enteral feeds. Do not keep on giving the IV fluid. As Sir emphasized, even in this case of a shock, stabilize the baby. As soon as you think that the baby is out of the shock, start giving enteral feeds as soon as possible. So identify the baby which is in the need of IV fluid, then only give these babies the IV fluid. And when you are giving IV fluid, please take care of your cannulas. There should be no extravasation because it's actually a nitrogenic injury. So that may be again harmful. So regarding criteria for hypoglycemia in the neonates in first 24 hours.
30 milligram. This last question, same again.
I think sir, ये शायद question is being asked because of that AAP criteria. जो to अगर कोई IV fluid पे है baby, so you can be very clear. जैसे first 24 hours में भी है, तो for an IV fluid baby, you should keep it always about 45 milligram per deciliter, जो hमारी definition लेके चलते हैं ना case of hypoglycemia. But yes, as sir said, in first 24 hours, you can even accept a little lower value. Because I think this question is being asked by Dr. Abhishek, if I'm not wrong, related to AAP criteria. So that is related to the AAP has given this criteria only for a late preterm and a term SGA or infant of a diabetic mother or a large for gestation age. So that is very specific. For a symptomatic baby, they have taken a cutoff of 40 milligram. For an asymptomatic baby, first 4 hours, they have taken a cutoff of 25, and after 4 hours, they have taken a cutoff of 35. So 25, 35, first 4 hours and more than 4 hours. But again, do not get into all these confusions. Better to remember one value and go with that. So you might miss a baby with an hypoglycemia if you go on taking these smaller values. And because we know that follow-ups are a little difficult. When you're working in a government setup, you might miss taking a baby with an hypoglycemia, again, a repeat blood sugar level. It is always better. Remember one value, 45 milligram per deciliter, and try to keep the values above it.
Initial hours values are very tricky to. Any more questions? Avoiding IV fluids as far as possible, using enteral feeds, keeping IV line secure, preparing IV fluid aseptically, identifying shock early, and titrating the inotrope dosage and for escalation and de-escalation as well. Maintaining euglycemia and TBC care.
Okay. Thank you so much, sir. Thank you, sir.
Thank you. Thank you all for the lessons learning. Thank you, Gunjan.